Good morning and welcome to all of you on this Sunday morning. I would like to thank Dr. Pradeep first for this opportunity and for designing such a nice course. As he said that all of us are using these diagnostic methods and all of us learn how to use them, the basics, but unless we know the traps and hazards, unless we know where the imaging can give us some information which can be misinterpreted, we will not be able to get the accurate and the exact diagnosis. So I'll be dealing with OCT angiography. So OCT angiography gives us images about the vascularity of the retina and the choroid. So in that we'll just discuss few situations where we feel that the vascular networks detected by this technology, are they actually there or not, and whether we should be treating all of them or not. So just to give you a brief overview, what is OCT angiography? It is a dye-less technique where we don't have to inject any dye and still we can get the vasculature information about the retina and the choroid and the optic disc. So what is the basic principle? You have a red blood cell moving in the vessel from one point to another. You have an OCT signal generated by this. As it moves here, the OCT signal decorrelates. So the software today is able to interpret this decorrelation and put it into an image format. So these are flow images. These are not morphological images, but this is showing you a flow of something from here to here, which in this case is an RBC. So it gives us a flow image. So why do we need this? We already have a fluorescein angiography and we already have ICG. So you see the problem with fluorescein is it doesn't show you the choroid that well. It only shows you the retinal vasculature. Problem with ICG, good point with ICG is it shows you the choroid as well. But the problem is that everything is superimposed. You have the choroid, you have the retina, you have intermediate networks, vascular networks, but all the vascular networks are there on top of each other. So sometimes you can be confused where actually the leakage is happening, where actually the problem is. So the best part about OCT angiography is you can segment the networks. You divide it. You can capture just the top part, the superficial retinal vasculature, the middle part, the deep retinal vasculature. You go deeper in the retina, it is avascular, so you will not get any major image. Then you go down, you can get the choriocapillaries and the deeper choroidal vessels. So that is the main thing, you can segment the vasculature. Just to show you one broad image, the machine gives you some output like this, where you have the superficial network. Now how do you know what is this network? This you have to be very careful about. These two lines are the lines in between which you have segmented the image. So this is green, so this is green. So that means this window is showing you what is in between these two lines. So this is deep network here between these two. This is superficial, this is further deep, then this is into the choroid, and this gives you a composite superimposed image also. So now here the machine auto segments, but that is where the traps are. So we'll just discuss that a little more. So I'll tell you some artifacts, and then even if we see the vessels, do we treat them or not? Do we retreat them or not? And then a little discussion about the non-flow areas or the hypo areas on OCT angiography. So there are simple artifacts like motion artifacts and other things. I'm not going into that because those can be very easily picked up and sometimes the machine also can do away with it. Now this is one important artifact to be understood. Projection artifact. What do you mean by this? So I just told you that as the RBCs flow, we get the decorrelation signals. But all the light is not being reflected back. Some light passes through and is going to be reflected back from a surface which is highly reflecting below it. Suppose this is the retinal pigment epithelium, which is a highly reflecting surface. So this will also give a mirror image of something which is happening over here. So this motion is being projected here as well. So if I segment a slab here, I'll get the same motion. If I segment a slab here, I will still get the same motion. So I can get confused where actually the motion lies. So this is a projection artifact you have to understand, and using other clues decide where is the right motion position. So I'll just show you one example. So this is an auto segmented image, but you see this is the deeper cut, but you are seeing the superficial retinal vessels also here. How come? There's no vasculature supposed to be here. So this is basically the superficial retinal vasculature has been projected onto this. So I have to do away with this. Sometimes my machine can do it for me. It has a software where it can remove artifacts. So now once you remove the projection artifact, it does away with it. But again, this has its caveats. Sometimes you can lose useful information also. So you should analyze with artifact removal on and without artifact removal on also. So you see here, this patient has drusen. Now from the hills of the drusen, you get projection of the superficial vasculature, which gives you this supposed hyper-reflectivity in the deep layer. So this is again not some abnormal hyperflow which has come up in the deep layer. It is just an artifact. The same you can get on other machines also. Swept source is a little better at it, but still you are getting some sort of a artifact because of these bumps. So this projection artifact has to be taken carefully. And then you get below the bumps, you get this shadowing artifact, which is not again hypoflow there. So you also have to correlate the scan with the Bscan. Now in the Bscan you have a feature which gives you the flow. So this red and this purple is the flow. Here if you see the image, there seems to be some sort of flow within the pigment epithelial detachment. But if you go back to your Bscan, actually there is no flow here. So this is again a sort of an artifact which is happening. So always, if you are not very sure whether the flow is there in the on-fast image, correlate it with your Bscan. Then like I said earlier, you have to check segmentation. So now you are getting some abnormal vascular networks in this scan as well as this scan. So where do they actually lie? Because that is very important to differentiate between a type 1 and a type 2 neovascular membrane. A type 2 membrane would be above the retinal pigment epithelium. This would tell me that it's a type 2. A type 1 would be in the choriocapillaries layer. This will tell me it's type 1. So am I dealing with a mixed membrane? No, again go back to your Bscan. You see this hump of the RPE. So most of the segmentation is happening below it, and the actual network which is being captured is below it. So I would still call this a predominantly type 1 membrane. So you have to check the segmentation and then only try to say what are the types of membranes. So again, when you have bumps, the auto segmentation machine gets confused. So you are getting segmentation here through the retina, you are getting segmentation here below the retina. So you might get some erroneous sort of images. If you see the composite scan, you might feel this is a new vascular network which has developed here, but actually this is nothing. These are all projection artifacts, and because of the segmentation, combination of a projection and segmentation artifact. So you have to be very careful while you are interpreting these images. So these three things will help you. And this is what the machine segmented for me here. It is giving me a choroidal neovascular membrane, but see here it's giving me in the deep retinal network and the superficial network. Do the networks exist there? But if I segment it, now fortunately some machines have a facility where I can change the segmentation. So now I've changed the segmentation. Now I'm getting a much better image, and I know that the CNVM actually lies where it should be, in the choriocapillaries or the RP level, and the superficial ones are normal. And correlate clinically. Everything is not a choroidal neovascular membrane. You're getting an abnormal network here, but this is the deeper angiographic level in the retina itself. So this is actually a parafoveal telangiectasia and not a choroidal neovascular membrane. So I'll just show you this example. Fundus looks fairly dry, OCT looks fairly dry except some bumps are there. But when I do an OCT angiography, I do find an abnormal network of vessels. This is a patient of dry AMD with abnormal network of vessels. So now there are few studies which have shown that even in the natural history, subclinical neovascularization can develop in dry AMD, which they are being labeled as non-exudative wet AMD. So the exudation has not started there, but the vascular network exists. These have been detected now with various studies, and people have also shown that those who have these vessels have a higher incidence, a 14% higher risk of going into exudative RD. But still, with the current information, we are not yet treating these. Maybe in the future we might be, but right now we are not. So you have to be a little careful about these vessels. Then you have scar tissue, but still you will have some vessels remaining. These are more well formed. The network is not dense. These are sort of dead tree vessels. Again, we don't need to treat them even if we are detecting them on OCT angiography. Another example of a bunch of dead tree vessels. And something, if you have a scar which is not too dense, you might, because of the RP atrophy, start seeing the underlying network. So this is unmasking of the underlying network. Again, not a new vascular network which needs treatment. So now this was a case of choroiditis who developed a secondary CNVM in which I gave an anti-VEGF injection. patient symptoms resolved, fluid resolved 6 by 6. You do an OCT angiography, you still see persisting vessels. Now, do we treat him? So at present, yes, we don't have a very definite answer, but for the present, we are not treating again just vessels which are persisting, because again, we know that anti-VEGFs won't totally do away with these vascular networks. I'll show you another example. This was a case of Best's disease who came to us with a problem. He was actually already had an injection in the left eye done. So we did an OCT angiography. We found a vascular network, but at present he was not too symptomatic in this eye. We examined the other eye. The other eye network appeared to be normal. This is the vitelliform lesion, but no vascular network. So we just followed up this patient. After 1 month, you see the better eye, the right eye, has started developing a vascular network, and he is also slightly symptomatic in this eye. So this is a new network which I am seeing. This I did treat. We gave him an intravitreal injection in this eye. And so this is another patient I am showing you. He had already been treated outside and had a vascular network here, but now again for the past 3-4 months he was asymptomatic. He had just come for a second opinion and sort of a review at a different place. So this network looks quite significant here. Should I treat it? No fluid on OCT. Patient is not symptomatic. We discussed with him. I told him we have both the options. At present, the patient opted for waiting. So we waited, but he came. This is November 16. He comes back to me after about 6 months. If you see the image, the network is gone. But again, be careful. This is a trap. The machine has not segmented the image properly. You are seeing the network more in the superficial layers. The deep layers, you are not seeing the network. Even here, if you see the segmentation, the abnormal vasculature lies right here. This is being totally missed. And in this also, it is being captured in this. So if we segment it better, if I take the whole entire segmentation, then I start seeing the network right at the correct place, and it is a little larger network. And since he had also developed some fluid on the normal OCT scan, so we injected this person at this time. And later on we can see that part of the membrane is showing regression. So actually, how do you classify regression by this? We don't have very definite answers. This is one paper which has been accepted, which we did on idiopathic membranes, and we have given certain criteria. Now we defined something called marked resolution, where we see that after an anti-VEGF injection, if the neovascular network gets highly fragmented, and the size also reduces by more than 50%. I call it moderate regression, when I can still make out the network. It's not totally fragmented, but the size has obviously reduced more than 50%. And minimum resolution if it is still persisting and also the size is not reduced by more than 50%. Maybe we can use this and judge as a criteria to titrate our anti-VEGF injections. So this is just an initial paper by us, but we might get more modifications in the future. And this is also only we have done for idiopathic neovascular membranes. So marked resolution, moderate and mild resolution. So now this was about the hyperflow areas. Now I will tell you something about the lack of flow, hypoflow. So a hypo area on OCT-A, does it always mean a lack of flow? So this is a patient of CSR. Even in a case of CSR, there is some signal attenuation and you get a patch of hypo in the choriocapillary segmentation. Does it mean there is choriocapillary ischemia here? Well, I don't think so. Sometimes I've also seen patients, Dr. Pradeep gave me an image, I have not been able to put it. You also see a hyper image in CSR. But I think these are just again machine artifacts, though sometimes people are claiming as hypoperfusion and detection of choroidal ischemia and other things, especially in AMD also. But we have to be very careful of the machine artifacts. Now again, a patient with drusen, again you are getting this hypoflow areas. I would not necessarily say that this is choroidal hypoperfusion, and this is the stimulus for anti-VEGF and later on CNVM development. It is again partly shadowing and partly artifact because the images in the decorrelation signal is not being picked up. A CNVM with a halo. Now the halo is there here as well on the ICG. Now I would also again not say that this is choroidal ischemia happening here. I think it is just the non-vascular part of the membrane itself. The vascular part gets stained, the non-vascular part doesn't get stained, and the same non-vascular part is probably responsible for this flow, lack of flow, and not a choroidal ischemia. This is a case of VKH. You see the hypo areas on ICG, you see similar hypo areas on this, and there are some papers which are saying again this is choroidal ischemia or the choroidal capillaries are getting blocked. But you see the same patient, I've given him steroids, and just after 1 week, once these areas start resolving, even you start seeing resolution on the OCT angiography. I don't think choroidal ischemia can recover in 1 week. So I would still say this is because some lymphocyte infiltration where you're not getting the images. But anyway, so whenever you see hypo areas here also, analyze them carefully. The hypo areas could be simply because of shadowing, or the machine is not able to get the proper decorrelation analysis. It could be because of slow flow also, or sometimes actual lack of flow. So these are some things which have to be taken care of when you are interpreting hyper or hypoflow. The technology is definitely impressive, but we have to ensure a proper image acquisition first and understand the possible artifacts, of which the most important I think are the projection artifacts and the segmentation artifacts. And we should not interpret it in isolation, always correlate with other history, fundus and OCT findings, and then take a decision whether you need to treat this vascular membrane or not. Thank you. Thank you.